began last year. However, a cap of 960 hours per year, equivalent to 80 hours per month, which is considered the death from overwork. This is a well-known term, karoshi line in Japanese language, exceeding max of 720 hours per year in general industry. A special exception was also made for doctors in charge of emergency and remote or rural medical care who are allowed to work up to 1,860 hours per year. This exception is scheduled to expire in year 2035. So this is my solution for this shortage, overtime work, and serious harmful events prevalent. We call it e-diagnosis based on the CDSS, Critical Decision Support System, including UpToDate, PubMed, and Google Scholar, which is useful as a diagnostic aid in difficult cases. By appropriately utilizing this system for difficult cases, it may be possible to maintain patient safety and doctors' well-being, even in the face of a shortage of physicians, addressing some of the critical challenges in healthcare delivery across rural and remote regions of Japan. So in search engines or AI, if you enter key symptoms, physical signs, and testing finds of your patients, relevant information from extensive medical literature will be found. So this is the actual case from my experience. 70-year-old woman with a 3-month history of edema, abnormal hair growth, and numbness in the legs. The edema was present bilaterally in the legs. Also, abnormal hair growth, increased hair growth was found both legs, and also numbness in the legs. The numbness, the location is the stocking type location. Now let's think about the potential diagnosis for this case. You can input the appropriate clinical terminology based on these findings, symptoms. You can use the PubMed or Google Scholar or UpToDate. So I can wait any responses using the Q&A or chat box. If you can use the chat box, that's okay. Or if you can use a Q&A box, that's okay. Anyone? So maybe resident physician participating in this webinar. So you are welcome to input your correct differential diagnosis. You can input findings, and you can look at the results of the clinical decision support system. Okay. Is there anyone who volunteered to show your differential diagnosis list based on your results from CDSS? So I can give you a hints. Use the term appropriate clinical terminology. So I used actually for this case, using the terminology is edema and hypertrichosis and polyneuropathy. So please use the term appropriate clinical terminology. edema, hypertrichosis, and polyneuropathy. Remember, the numbness with stocking time distribution suggests polyneuropathy. Okay, maybe there are people who actually got the lists. So let me proceed. Oh, there is a response from Jahir CJD. Oh, there is a correct answer. Congratulations. Anonymous response says Poemus syndrome, a rare paraneoplastic disorder caused by plasma cell dysplasia. Polyneuropathy, organomegaly, endocrinopathy, monoclonal plasma cell disorder, skin change, including hyperpigmentation and hair growth. Congratulations. So diagnosis is actually the patient had Poemus syndrome, which is also called as Crow-Fukase syndrome. Fukase is the name of a Japanese doctor. So relatively rare disease, but in Japan, we see this these kind of patients sometimes. So thank you very much for participating in this case conference. Thank you very much.
Right. Thank you very much, Dr. Yasu, and also thank you to our attendees who participated in the case conference. Right. Congratulations to the one who got it correct. And now we will move on to our fourth and last speaker for this webinar. I'm pleased to introduce Dr. Jennifer Benjamin, Regional Customer Success Specialist for South Asia, Wolters Kluwer. Dr. Jennifer, please.
Thank you. Thank you for joining us today, actually, and giving us your time. So my name is Dr. Jennifer, and I'm the Regional Customer Success Specialist for South Asia. And today, for the last topic, we wanted to bring everything together to the point of clinical decision support system. So let's begin by reviewing some of the challenges the clinicians are facing today and why a clinical decision support is becoming a critical consideration. I'm also going to provide an explanation of clinical decision support system, the benefits, and how you can evaluate the impact of using a CDS solution. I'm also going to share some details about Wolters Kluwer's solution, clinical decision support solution called UpToDate. Dr. Yasuharu had also mentioned the same, and let's get started. So right now in front of you in this slide, you will be noticing the numbers of, I think the alarming numbers, what we may be aware. So down below, you can see by 2030, there is already a prediction of 10 million doctor shortages. And the other on the right is more of US numbers, which is still, I think, even though it is the most developed country or the leader in the world, they are also facing the same shortage, which all of us are facing. So irrespective of your GDP or your economic wealth, irrespective of it, health structure is still crumbling, and when it comes to shortage and burnout. Now, we had our other panelists talking about their respective countries. I'm based out of India. So to give you a little bit of perspective, of course, WHO has given us that the ideal or the expected, doctor-patient ratio is 1:1,000. But in India, we recently had an announcement by the health ministry telling us that we have attained 1:836. Of course, if you look at it if you look at the numbers a little bit more deeper, this is after the inclusion of almost 500,000, more than 500,000 traditional medicine practitioners as well. So what it means is your Ayurvedic doctors, your homeopathy and other traditional medicine practices we follow in India, added to the more than 1 million doctors who are practicing allopathic medicine in India. Now, if you take this ratio in rural areas, of course, it's going to be even significantly worse. And there is a significant shortage of doctors now in India when it comes to community health centers. So it has jumped from a 45% in 2005 to an 80% in 2022. Now, how do you address these concerns? Now, it has become it is a requisite that you have to do a comprehensive approach. And our doctors, panelists previously have relatively done the same. So this is obviously, it includes improving your infrastructure. You have to standardize the care practices. You have to enhance the training programs and ensure a regulatory compliance. Now, how did US, of course, tackle, the growing gap? So their nurse practitioners and physician's assistant, they are now trying to fill the gap, but of course not able to do so effectively. And another great example, what we had live unfolding in front of us last year, or even so now, is the doctor strike in Korea. This was, of course, triggered by the healthcare reform plan, where they had proposed expanding the medical school admission quota in February 2024, a massive walkout by the clinicians. Almost 35% of the hospital's doctors had vanished overnight. And all we were left with, or all Korea was left with, was the remaining doctors, nurses trying to fill the gap, trying to hold the fort, essentially, and burning out in the process. So what other contributors are also, what are the contributors to the shortage? So you have your brain drain. So essentially, I think Dr. Eddie had also mentioned this, where many qualified doctors are now migrating to the other countries for better career prospects and higher salaries, and leading to a loss of talent. So now that is one place where we can tackle, where we have an infrastructure in place where it is attractive enough for them to come back to their own countries. Then we have your urban-rural imbalance. So a significant number of doctors are now preferring to work in urban areas. And of course, it is due to better infrastructure, the higher salaries, more opportunities for a career. Now, what happens? Of course, it leaves the rural areas with a severe shortage of medical professionals. And now in terms of education and training, of course, the limited medical seats when it comes to the growing population. So the population is continuing to grow. And of course, in case of India, we have become one of the most populous country in the world. And the rate at which we grew was exponential. And of course, the medical seats continue to be stagnant until the last few years. And the infrastructure, of course, continue to be inadequate, especially in case of rural healthcare facilities and the high population growth again. So of course, what happened, the demanding nature of the medical profession, and when it is coupled with the inadequate support and the long working hours, it essentially led to a burnout and dissatisfaction among the doctors. So what you see in the slide now is essentially a 66% globally, the doctors and nurses are facing burnout, and 31% are essentially telling us that they are looking to leave their clinical role in the next 2 to 3 years. And the volume of decisions which a clinician has to make every day, and the push to become efficient, it has made it sure that what you have always done before is not enough. Medical errors and care variability now are leading to poorer patient outcomes and lower job satisfaction. All these are weighing heavily on the clinicians, and now it is leading to higher turnover than forecast, and it is further, of course, impacting our patients. Now, while we talked about the immediate shortage and burnout, what else is, of course, adding to it? It is the sheer volume of medical information, and it is growing at an unprecedented rate. So if you want to add numbers into it, every year, at least 1.8 million to 2.6 million studies are being published. Articles and journals, they are being published every year. And nobody has time to go through this to ensure they are up to date and they are able to provide the best efficient care for their patients. And these latest evidence-based information, they may not be readily available to every clinician. And it is, of course, adding to the significant challenge to healthcare professionals. And in many regions, of course, there could be either absent or contradictory evidence complicating the decision-making process further. Now, resource constraints, I think this was also something we touched upon, and it was touched upon by the previous speakers. It is again further limiting the access to healthcare resources and reliable information. And when you have lack of access to the technology, so for example, at least in the world at a given point of time, 2.7 billion people are considered offline. And this makes it difficult for them to access the immediate up-to-date information. And it is, of course, taking away a large segment of the population. Many countries are also now lacking the ability to make this medical education training available immediately. And it is not only impacting bringing the new clinicians into practice, it is also affecting the ability of the current practitioners to stay current. Now, what happens, of course, because there are real consequences to getting it wrong, the layers of decision making now, everything is now impacting the patients. So if you look at the slides right now, so you can see how it is, of course, impacting the patients and how it is costing our healthcare system. WHO finds worldwide there is at least 1 in 300 chance of injury occurring in or during a treatment of a patient, and 10% of being harmed while in the hospital. Surgical procedures, if you take that into consideration, 7 million patients are affected with disabling complications, and 1 million die. The New England Journal of Medicine found that not even half of the patients are receiving the recommended treatments. And when you think about the cost, 42 billion US dollars are wasted when it comes to medication errors. And 15% of health spent is wasted, again, dealing with the adverse events, trying to compensate for all the complications. Ultimately, of course, all these effects are creating a storm leading to poor patient outcomes. So this is where globally, hospitals are now tackling challenges through a technology stack, specifically a clinical decision support technology known as CDS. CDS is helping a healthcare professional make evidence-based diagnosis, treatment decisions while they are along their patient journey. Now, if you want to look at the numbers or the impact of a CDS solution, especially in case of UpToDate, now, a recent study shows that at least a clinician, during a clinical day, they have 15 to 20 clinical questions while they're treating their patients, right? Out of which 60% are going unanswered, which is a huge amount of uncertainty, which is driving your patient's care. And now, when they have a CDS solution at their disposal, they're able to answer those questions, and at least 5 to 8 decisions are changed. Now, when they have access to this information, at least 1/3 of the treatment decisions are improved. The rest are validated, right? And it's pretty reassuring when it comes to both clinicians as well as the administrators, and frankly, patients, because there are also embedded patient education tools, which is now going to help you as a clinician make a shared decision making with your patient and improve health literacy along the way. If you want to put numbers to Asia Pacific region, in 2024 alone, UpToDate was accessed 49 million times for topic searches and finding answers. And out of which 81% of physicians in our region have acknowledged that UpToDate has become their point of care resource. And they have also agreed, 97% agreed that UpToDate improves the quality of care provided to the patients. And 96% agrees that UpToDate is saving time for them. Now, this is again the independent studies which UpToDate, different institutions, different hospitals, everybody has conducted on UpToDate. And if you can see here, significantly fewer tests are being ordered, especially after implementing UpToDate, because better decisions are being made at the point of care. Fewer diagnostic errors are now being made to getting it right the first time around, and especially it helps with the hospital budgets as well. In fact, there is typically a return of investment within the first year of using UpToDate, which essentially means UpToDate is paying for itself. So what do we have? What do we have in this space, or what is our future in case of UpToDate and our clinical decision support? Wolters Kluwer has always been recognized as a leader in its space, and we have been always at the forefront of innovation. There are many directions actually where our tools are being used at this point, and it is always to improve clinical efficiency and the patient outcomes. And some of them you can obviously see on this slide. Whereas what else is actually taking place right now, we are also able to revolutionize patient and chronic disease management in some key areas of medicine to improve clinical efficiency. Now, we have also found users in other domains, which is preventive patient care and value-based healthcare. So what this means is we are aiming to improve the quality, safety, and efficiency of healthcare delivery and to reduce cost. So this is where I also want to mention the buzzword, of course, which is artificial intelligence. It has essentially become the big word for us for the last 1 or 2 years, and it is for a good reason. And this is where we are also taking a moment to set a standard for responsible development of clinical generative AI. So UpToDate is setting the standard for the responsibility. And we are also partnering with different healthcare community and technology leaders to ensure that we are able to provide answers through our testing space, which is called AI Labs, so that we are able to prioritize reliability, quality, and transparency. So at the end of the day, when any hospital administration chooses to implement tools which has the latest technology, especially AI, I'm sure every institution takes a moment to evaluate the quality of the product which is being offered before anything is being purchased and dispensed, across an institution. So this is where I want to take a moment to conclude. Thank you for your time. And I want to reassure that Wolters Kluwer has been committed to ensure an adequate support is provided to the clinical workforce especially through our trusted CDS solution UpToDate. We will always be at the forefront of innovation, and we are here to ensure that we are meeting the needs of the evolving medical landscape and improving patient outcomes any given day. Thank you.
All right, thank you very much, Dr. Jennifer. And we'll now move into our Q&A session. So may I request all speakers to turn on their cameras? We have about 10 minutes, I think, for the Q&A, and we have received quite a number of questions from the audience. So we'll try our best to probably get through probably 2 or 3 of them. Right, so I wanted to ask the first question, just following up on Dr. Jennifer's conversation about the role of technology in tackling doctor shortages, right? So we do have this question asking whether the panel sees remote support, surgical collaboration tools becoming more important, and how that would ensure more doctors can support each other despite the location. So perhaps, I think Dr. Eddie, in your presentation, you briefly touched about the teleradiology platform, right, that Siloam has. Do you see that, has it already expanded to other areas of clinical care? Or do you see it being expanded into surgery, other types of consultations in the future?
Thank you for the question. Well, in Siloam, we are also exploring other ways of utilizing technology, but we are really careful when we talk about remote surgery. Well, Siloam has been investing in surgical robotic surgery, but remote surgery is something that is totally different from just a robotic surgery, because number one, quality and safety must always come first. Number two, with Indonesia, not every facility is ready. Many rural hospitals may lack the bandwidth, the equipment, or even the technical support to adopt these tools effectively. And number three, with surgery, we do believe that surgery is something that a doctor-patient still needs a human connection. With remote technology, that might not be built enough, and that might affect the clinical outcome as well. So I'm not saying that I'm against the idea of the remote surgery, but in the context of Indonesia and what we are facing right now, I don't think that implementing the remote surgery for Indonesia is the right time to do that. Thank you.
Right. Thanks very much, Dr. Eddie. So I think it sounds nice, but there are actually a lot of considerations that healthcare providers needs to take before going for it. So curious how that is in Japan. Dr. Yasu, what are your thoughts about the use of remote surgery, surgical collaboration tools?
Yeah, yes. When I was in the Ibaraki prefecture in Kanto area, close to Tokyo, there is a area of physician shortage, and new project is coming up, including AI remote surgery consultation services. Actually, University of Tsukuba developed that project. Professor of University of Tsukuba hospitals, they give them a consultation advice to the remote area, rural area physicians to conduct a surgery at the time of the surgery. So the video telecommunication is a critical the device for doing this communication, and the device is rapidly developing and modernized, including the image and sounds and the quality of the videos. So depending on the technology development, we can see a lot of new devices and technology for using the tele consultation and telesurgery.
Right. So I think as time passes on, perhaps the technology, the devices involved will become, I guess, more reliable and safe for the use of patients. Right. So we have a couple of questions on AI. I think that was what Brian, you touched quite a bit on your in your presentation. So there was an earlier question about how some doctors remain a bit hesitant about the use of AI. They are nervous. What that means on, I guess, the safety, the quality of care that they can provide. And there's also another new question coming in about how would AI actually change, increase even the scope of practice for healthcare workers other than doctors, and how that would actually impact the entire doctor shortage issue. So what are your thoughts on that?
Okay, thank you for the question. I think it's a good question. I think in a nutshell, AI is an assistant. It does help improve repetitive, mundane work. It's not here to replace any professional healthcare workers. I think with anything that's new, everybody is apprehensive. Everyone is cautious to embrace it wholeheartedly. So from our perspective, when we introduced AI, for example, in our radiology department, there were a big pushback by our radiologists because they're not sure what we will do. They're not sure about will it help in their interpretation of the results and the report. And they felt that it might just hold them back because they have to learn something new. But over time, we have implemented it for the last 2 years plus. They actually now embrace it. They love it. They find that AI actually helps them. They can do more cases. There's more throughput that can be done. It actually, the AI algorithms actually help them in the image analysis and flag up some of the potential diagnoses, and which actually in return allows them to focus on more complex cases. So the AI is of an assistant to them. It was something they resist, but now they embrace it. I think with anything new or technology or AI, I think the important thing it does not replace human, because the best AI empowers us. So I think whether you're a doctor or you're a nurse, I think, or anyone, I think you just realize that innovation will just empower us. Thank you.
Right. Thanks very much, Brian. And curious as well for Dr. Jennifer's thoughts. As you work with different customers across the region, do you actually sense initial hesitancy, and how has that changed over the years?
So when you talk about AI, I think physicians, of course, I think directly working along with my colleagues, I think they have jumped on the wagon, to be honest. Of course, we have heard ChatGPT, and I'm pretty sure when Dr. Yasuharu put out his case also, he did and push people to just check out how different tools would respond to his question. So I think, yes, people have asked, and they're finding, again, like how Dr. Brian said, they're finding it as an assistant to help them find answers faster. So they are not able to do the manual work, take out extra brain power just to do the manual work and just get to the answers faster. Now, this is where I wanted to just emphasize on the same point that we need to be responsible enough, not only as as any kind of a company or any kind of a solution offering, for example, in Wolters Kluwer, or even as a hospital administrators for my fellow panelists, where we have to be responsible enough to choose the right resources for our clinicians. They might be able to, as long as something is helping them to do the work faster, of course, they're going to jump on it. But again, the resonating feeling would be, should I double check the work which AI has given or has resulted, right? Do I have to double check? Is it going to take away more of my time? So I think those sentiments are something which the administrators can take out when they ensure that they have evaluated the solutions which is being bought for the hospital and for their clinicians. But I think when it comes to end users, especially the clinicians, the nurses, anything that helps them to make them work faster, they're never going to say no to it. And if you think about it, we are now sitting in online platform. Before COVID, I think we were more around, especially in India, we were more around physical conferences and everything. Now we are more open to online. We see the, we have to move along with the tide, right? So AI is here to stay, and we have to embrace it at some point.
Right. All right. Thank you very much, Dr. Jennifer. Yeah, I really wanted to ask one more question, but I think, the questions around retention, around scope of work, I think that would easily take us another hour to go through. So I think, yeah, here is probably a right time for me to end the webinar. So I would like to, of course, thank all the speakers for taking time this afternoon to share your insights with us. Also, thank you to our audience members who joined us this afternoon. We do have a closing poll question to just get your quick feedback on how you felt about the webinar so far. So just help us fill that out before you go. So yes, thanks once again to all our speakers today. I hope it has been a valuable session for you as well. And to our audience, do look out for our other HMA webinars in the coming months. Right, we will see you either at the webinar or at our physical HMA conference happening in September in Vietnam. All right, thank you once again to everyone, and have a good day ahead. Okay. Yep, I think we can close our cameras, I think. I think. Wait.